All right, welcome everyone to this joint CAREX Canada and WorkSafeBC webinar, where we'll be providing information on exposures to antineoplastics or cytotoxic drugs in Canadian workplaces and facilitate a discussion about how to best address those exposures. My name is Alison Palmer. I'm the Managing Director for CAREX and your moderator for today's webinar. I'm joined by Amy Hall from CAREX, as well as Priscilla Percy Chua from WorkSafeBC. Also on the line are our panelists, Cheryl Peters, Tanya Pon, and Kelsey Van Pelt, who I'll introduce once we begin the panel portion of the webinar. So the format for today's presentation is as follows. We'll have 45 minutes worth of presentation and then 15 minutes worth of questions with our panelists. Our panelists will remain on the line afterwards if there are any further questions. So I'm just going to tell you a little bit about CAREX before we begin, and a little bit about why we're here. So our goal here, the goal of the CAREX Canada project, is to inform efforts to reduce Canadians' exposures to known and suspected carcinogens. So that involves workplaces and community environments. So we look to identify what carcinogens are Canadians exposed to, both at work and in the community. Where do those exposures occur? How many people are exposed? And where we can, to what extent workers are exposed. So I should note that the CAREX project is funded by the Canadian Partnership Against Cancer. An important side note, and the relationship here with WorkSafe, is that WorkSafeBC provided the seed funding for the CAREX Canada project back in 2003. And once the project established estimates of exposures to known and suspected carcinogens in workplaces across the country, we partnered with the WorkSafeBC Risk Analysis Unit. That was in 2012, and we established a working group. And this working group meets twice per year, face-to-face, to discuss emerging issues, inspection priorities, research needs, opportunities to collaborate, among other topics. So this webinar today illustrates some collaborative work we've done on an emerging issue, which is exposures to antineoplastic drugs or cytotoxic drugs. The objectives for today's webinar is to discuss and define antineoplastic or cytotoxic drugs, to identify who is exposed and the associated risks, to discuss how risks are assessed and controlled, and then to offer a panel discussion and Q&A period. So the reason why we're focusing here on this particular exposure is because exposure to antineoplastic or cytotoxic drugs is very much a dynamic issue, and we've identified it as a priority, as has WorkSafeBC, given the increasing use of less invasive treatments for cancer and other conditions. So now I'm just going to introduce our presenters. I'm going to hand it off to them, and they'll continue the presentation here. So we'll start with Amy Hall, who's an occupational hygienist. She consults with CAREX to assess occupational exposures to hazardous drugs. Today, she'll be presenting her research related to antineoplastic agents or cytotoxic drugs. Amy is also a PhD candidate at the University of British Columbia's School of Population and Public Health, and her research focuses on shift work. She also holds a Bachelor of Science in Nursing and a Master of Science in Occupational and Environmental Hygiene. Percy is a certified industrial hygienist, registered occupational hygienist, and a certified registered safety professional. She has extensive experience in developing and implementing a hazardous drug exposure control program within a health authority, as well as conducted funded research to determine the extent of healthcare worker exposure to cytotoxic drugs. Currently, Percy is a prevention officer with WorkSafeBC. So we'll start off here with Amy.
Thank you, Allison. So I think first maybe we can talk about a bit of terminology here. Hazardous drugs are those that have demonstrated carcinogenicity, developmental or reproductive toxicity, organ toxicity at low doses, or damage to genetic material in humans or animals. And a lot of hazardous drugs are referred to as antineoplastics. And this term describes a wide range of drugs that interferes with cell proliferation. And there are quite a few out there. As of 2016, Niosh, the National Institute for Occupational Safety and Health, had classified over 100 antineoplastic drugs as hazardous. And these are used to treat a variety of medical conditions, but the bulk of their use does occur in the treatment of cancer. And today we're going to be referring probably quite a bit back and forth between antineoplastic drugs and cytotoxic drugs, and that's just, they're essentially referring to the same thing, but it's a matter of, CAREX versus WorkSafe, the most common terms that we tend to use. So you'll hear both. So as I mentioned in the previous slide, there is quite a range of possible effects arising from exposure to antineoplastic and cytotoxic drugs, since these drugs can harm healthy human cells and tissues in addition to the ones that they're designed to treat. So in cancer patients and others receiving the drugs in high doses, there are acute and long-term effects that are well established. So organ damage, increased risk of infertility, cancer, secondary cancers. And so occupational exposure typically happens at much lower intensities, but this is expected to be happening again and again over time. So we're talking about being concerned about the effects of chronic low-dose exposures in workers, and these types of exposures have been linked to sort of immediate thermal and allergic effects, as well as DNA damage and increased risk of reproductive issues and increased risk of some cancers as well. So one thing to remember is that antineoplastic or cytotoxic drugs are inherently hazardous, and so there's no safe level of exposure, so the general aim being to keep exposures as low as reasonably achievable. In terms of ways that people can be exposed, there are a number of exposure routes. So there's contact with skin, orally through hand-to-mouth contact, inhalation of aerosolized drugs or residues of the drugs. There's ocular exposures possible. Also injection could happen, but the majority of persistent low-level exposure is expected to occur through the dermal route. In terms of how exposure can happen, one way is through direct handling of the drugs. So here we'd be talking about people preparing or administering them, but exposure can happen indirectly as well through contact with contaminated surfaces and objects, or through contact with contaminated fluids excreted by patients who are receiving the drugs. And it's important to note that a lot of antineoplastic drugs are stable and their residues can deposit on surfaces and persist in workplaces for long periods of time. So exposure is expected to be a possibility, even in situations where exposure controls have been implemented. A range of research has found that contamination persists. So it is something to keep in mind. Another important fact is that exposure scenarios, as Alison mentioned in the intro, are changing. So traditionally we've seen a lot of exposure happening in hospitals, but there's also been lately increasing use outside of hospital environments in community settings such as vet clinics, community pharmacies, and home care. And these changes have been driven by a number of factors, one big one being the increasing availability of oral antineoplastic or cytotoxic drugs that can be more readily used outside of hospitals. There are new oncology programs that involve companion animals, so a lot of research into dogs and treatments that then can be translated to humans, so that we see more treatment happening in vet clinics. And also just the fact that the population is aging, and so there needs to be more treatment options, and so the use, again, of the antineoplastics that are in oral form can be more likely to be happening outside of hospitals. So this is important because hazard awareness and exposure control measures may be quite different in non-traditional settings, sort of outside of hospitals, especially given that these are kind of emerging exposure scenarios. So who may be exposed? There are quite a number of occupations based on what I've mentioned so far that may be exposed. And as I mentioned before, it's not only the people who may be handling the drugs directly, but also those that may be contacting contaminated surfaces, so cleaners, for instance. And these are traditionally pretty understudied occupations in this area. So we know that quite a few people may be exposed, and this could be happening in a number of workplaces, but there's actually surprisingly little information available to describe where and to what extent these exposures are happening. And this kind of information can be quite useful with respect to exposure surveillance, identifying groups at high risk of exposure, and targeting future research and prevention activities. So this led CAREX to develop national level estimates of occupational exposure to antineoplastic or cytotoxic drugs. And we did this by work location, occupation, and sex. And where we could, we also tried to give a characterization of relative exposure levels within occupations. And so we will just briefly summarize in the next couple of slides our methods and our findings. And these have been all posted on the CAREX website. I believe they're all current versions of the results. You can access that as well. Just a few notes. Because CAREX doesn't conduct primary data collection, all of our estimates rely on secondary data sources. So these are high-level estimates. There's not a lot of granularity to describe exposure scenarios. We did assess exposure as a group rather than looking at individual drugs. And this is partly because just out of feasibility, we just couldn't do that for individual drugs, but also workers tend to be exposed to more than one at a time because the treatments just involve combinations of drugs most often. We defined exposure as any potential for worker contact with the drugs, either indirectly or directly. We didn't differentiate between exposure routes, and we also didn't differentiate between drug formulations, the oral versus IV drugs. And we tried to assess as many occupations as we could, given the information available, and these are listed on the slides here. So there were substantial differences in the data available to do this for each occupation, but the strategy that we used was generally consistent. This is our framework, and it's also, I believe it's also online. So generally speaking, we just first estimated the proportions of people likely exposed within each occupation based on a review of peer-reviewed literature and gray, unpublished literature that describes similar exposure scenarios in Canada and where we needed to find additional data in the U.S. or the EU. And this proportion of those exposed was combined with baseline numbers of workers in each occupation in Canada, and this was found from data sources ranging from the Canadian Census or register reports from professional bodies where we could get that kind of info, human resources data compiled by the Canadian Institute for Health Information, and so on. And on the right here, you see there is a little summary of our exposure level estimates, and so we did this. We categorized people into low, medium, and high categories to just give a general characterization of exposure differences within occupations. And we did this by combining information on the general frequency of use of the drugs within an occupation, and so combine that with the exposure controls expected in a given work environment. So just briefly, as this info is available on the website, for our prevalence estimates, we estimated that about 75,000 Canadians are occupationally exposed to antineoplastic or cytotoxic drugs. The largest occupational groups exposed are pharmacy workers and nurses, and over 3/4 of those exposed are female. Of course, the proportion of female to male, the ratio differs by occupation, and in nursing and in pharmacy technicians, we've got a lot of females working in those occupations. We have also indicated on the right here some worker groups where some amount of exposure is likely happening, but we weren't able to assess exposures due to just poor data availability. for our levels of exposure, these are the results for the relative exposure categorizations. And given the broad scope of the estimates and the lack of the quantitative data available, this was just our way of kind of dealing with that. So it's best to pay the most attention to differences within occupations outlined here, rather than focusing on the total numbers in the bottom row. So low exposure was defined as a combination of low contact frequency and high control. A moderate exposure was defined as either a combination of low contact frequency and low control, or high contact frequency and high control. And then in our high exposure category, this was defined as a combination of high contact frequency and low control. So you can see, as an example, for pharmacy workers, which is the top occupation, we've summarized things by hospital, pharmacists, and community. And then within community, we've also we've got some people in the moderate exposure category, and that was due to a lower frequency of exposure to the drugs based on the literature that we reviewed, as well as relatively low exposure control in these areas, versus the high exposure, the 4,500 people in that group were those that are expected to be handling the drugs more often, or in environments where the drugs are handled more often. So as a quick summary, again, we've estimated that about 75,000 people are exposed to antineoplastic drugs in Canadian workplaces. This is likely an underestimate because we weren't able to assess everybody that we needed to, and we tried to be as conservative as we could with our proportions exposed. An important point is that there's a high proportion of females exposed, and given the health risks associated with these chronic low-level exposures concerning reproductive effects and so on, this is important to pay attention to. And also the fact that about half of exposure is occurring in sort of emerging environments outside of hospitals is worth paying attention to, since the hazard awareness and controls may be less developed in such workplaces. So I'll leave it there, and now Percy will provide a bit of information about legal requirements and risk assessment.
Thanks, Amy. So before I start off with my talk, I just wanted to say throughout the presentation, the slides will state antineoplastic and cytotoxics, and it is used for consistency's sake. Because just a reminder that it does mean the same thing, and I recognize that cytotoxics is a more common term in the industry. So you'll hear Amy talk about antineoplastics, you'll hear me talk about cytotoxics. We're talking about the same thing. So let's jump right in and talk about legal requirements. So I've clumped them into three basic groups for hazardous drugs. And note that I've said hazardous drugs, as some of these requirements broadly cover hazardous drugs, which include cytotoxic drugs. So first is federal requirements. These are general requirements. In Newness, medications and drugs are exempt, but manufacturers can still provide a compliance safety data sheet, or SDSs, or additional documentation. Also, there is a general duty clause that requires employers to ensure the health and safety of all workers at their work site, which includes exposure to hazards. The second group are provincial requirements. So all jurisdictions in Canada have general requirements for workplaces to identify, assess, and control exposures to hazardous materials like cytotoxic drugs. But some provinces, like BC and Ontario, have developed specific requirements for these. For example, in British Columbia, there is a specific requirement to consider protective reassignments for pregnant women or for those intending to conceive or father a child. Now, in Ontario, for example, there are requirements within the Healthcare and Residential Facilities Regulation to develop measures and procedures, as well as other requirements. Finally, there's industry requirements. On occasion, there are industry-specific guidelines and standards which aren't legally required but are associated with cytotoxic drug handling. So, for example, in pharmacy, there is documents that have been developed by NAPA, which is the National Association of Pharmacy Regulatory Authorities, and the ASHP, which is the American Society of Health System Pharmacists. In nursing, there is an organization, for example, called the Oncology Nursing Society, or ONS. So moving on, we realize that there are numerous documents talking about best practices when handling cytotoxics or hazardous drugs. And we'll be talking about some of these points today. But please keep in mind that these are best practices. And while there might be some limitations to implementing certain practices at your facility, we'd still like to provide them as illustrations of what other facilities are doing. And perhaps your facility or organization may strive to implement some of these practices in the future when implementing a cytotoxic drug exposure control plan. As part of this presentation, we hope to open that conversation about best practices. Let's start by discussing risk of exposure in relation to a variety of workplaces that cytotoxic drugs are used. There are several factors and conditions that influence the risk of exposure. Some variables would include how cytotoxic drugs are handled. Work sites might differ in the tasks performed by workers, the amounts and concentrations of cytotoxics, what equipment workers use in conjunction with the drugs, such as counting trays or automatic pill counters, and what mechanisms or controls are in place to reduce exposure. For example, we can compare two work sites, a hospital cancer ward and a veterinary clinic. Both are involved in drug administration and patient care, and patients being for humans and for domestic animals. A hospital cancer ward is more likely to deal with high quantities of cytotoxics, while a veterinary clinic likely administers cytotoxics less frequently. Hospitals will often be able to access specialized administrative equipment such as pad pumps and closed system transfer devices, which can reduce worker exposure, while vet clinics are likely to administer cytotoxics by injections. While both work sites should have safe patient handling precautions after treatment, they likely differ in how they're carried out. So this just simply illustrates that there is a need for a safety program in the workplace that is site-specific. So this is done by assessing the risk of exposure to workers at your workplace in order to determine ways to reduce the exposure and building a site-specific exposure control plan. Now, an exposure control plan, or an ECP, might be a new program document for some. In a nutshell, it's a comprehensive program that describes the risk, determines the extent of exposure, and details the mechanisms used to minimize potential exposure. Now, the BC OHSR, or the BC Occupational Health and Safety Regulation, summarizes the components of an ECP nicely, which I've just cut and pasted on the slide. So ECPs typically have 7 components in them. First, statement of purpose and responsibilities. Pretty self-explanatory. Second is risk identification, assessment, and control. This is probably the most difficult but most critical piece as it narrows down what you're talking about and what the risk of exposure is. Third is education and training. So how are workers going to know what's in the program that will protect them? This would include training on equipment or workflow. Fourth, written work procedures. These are written reminders for workers to refresh them on training. Fifth is hygiene facilities and decontamination procedures. So in the context of cytotoxics, it discusses what to do in an event of a spill or uncontrolled release, and details how workers will clean themselves in the area post-spill. Sixth is health monitoring. Now, this isn't really required for cytotoxics, but it's applicable in ECPs on lead or asbestos. And 7, documentation. These are handling and training records. So let's tackle the risk assessment process. The risk to workers is assessed by an individual or a team who, through education, training, and experience, are knowledgeable about the work performed at the workplace, the hazards involved, and the means to control the hazards. So a qualified person is a competent person who has appropriate skills, knowledge, and experience in the work environment, practical understanding of what is being done or the process within the workplace, understands the health and safety requirements, and recognizes the assessment process and different factors of the work that may affect worker exposure and risk. So there is no certification associated with being a qualified person to perform a risk assessment in this circumstance. However, they might have a CIH, an ROH, or a CRSP. And these are people who are familiar with the risk assessment process. But they could be people like a pharmacist, a head RN, a vet tech, or anyone that meets that requirement stated here. Now note that throughout this process, consultation with the Joint Occupational Health and Safety Committee and frontline workers is really essential because it's the workers and their representatives that provide insight on what work is being performed and possible solutions. So how is risk assessed? Here's a simple diagram of the risk assessment process, and it basically has 3 steps. Identifying cytotoxic drugs that are in the workplace, assessing how workers may be exposed, and developing and implementing controls to reduce that exposure. So let's talk about each of these steps in the next few slides. First is to identify which cytotoxic drugs are currently being stored, handled, and used in your workplace. You're identifying those that have inherent toxic properties. So I believe we had a question when you signed up for the webinar that asked about, well, how would you do that? Where would you look? What kind of resources would you look into? So some few resources I've actually stated on the slide. You can look into the supplier, look at the supplier of the drug and ask them. You can also ask the manufacturer if they developed information sheets or a material safety data sheet or MSDSs. There are 2 publications out there that I've put on the slide that are very handy as well. It's the National Institute of Occupational Safety and Health, or Niosh, and they've published a list of antineoplastic and other hazardous drugs in the healthcare setting. There's the 2016 version, which is on here, and that is the most latest version that's kind of broken it down in terms of the newest and latest research. This is free online. The second resource is the Canadian Pharmacists Association. Their publication called the Compendium of Pharmaceuticals and Specialties, which is CPS, and they have drug monographs, and these are updated annually. So after you have identified, the second step is doing the assessment. So assessment is determining the extent of exposure, so whether it's low, moderate, or high. And while there are many factors to consider during assessment, as symbolized by the blank honeycomb here, here are just some to think about. So the first one is exposure routes, or routes of exposure. And we're going to start at the bottom and move our way diagonally up. So as Amy pointed out, inhalation, ingestion, skin or eye contact, injection from accidental sharps are potential exposure routes. So surface white sampling would be handy to determine if contact with surface contamination is a potential source as well. Second, potential effects from exposures. These can range from some mild ones such as contact dermatitis or local allergic reactions to some more serious ones like cancer and malformation in fetuses. Third is medication, or the form of medication. So the medication can come in different forms, such as coated and non-coated tablets, capsules, powders, liquids. You might want to also consider looking at packaging, so whether they're blister packed versus whether the pills are freeform. Another factor is work practices. So practices that are used when splitting or crushing pills, administering and cleaning, as well as precautions and safe handling instructions. And the last factor you might want to consider also is past incidences. So reported adverse health effects from workers, spills, issues reported via the Joint Health and Safety Committee, and issues regarding storage, transport, or handling. So I just wanted to emphasize that these are just some factors to consider. There are others out there as well that might be industry-specific or even site-specific. after you've done your assessment, the last step is control. So this is a common term that's actually used in the occupational health and safety industry to describe the priority of controls that can be applied to minimize exposure. So there are 5 categories of controls. The controls that are located at the top of the pyramid are more effective than those at the bottom. When possible, we try to use the controls that are categorized at the top of the pyramid first before moving our options down the pyramid. The top 2 tiers are elimination and substitution. So elimination means removing the hazard from the environment, and substitution means switching out the hazardous substance with another that is less hazardous. Now, in most work environments involving cytotoxic drugs, you can't do the elimination and substitution options. You just can't do that. So we defer to the last 3 methods of control, which are engineering controls, administrative controls, and personal protective equipment. So let's talk more about each of these controls. So engineering controls. These are controls that workers use passively. So they don't really need to do or activate the equipment, but it'll protect the worker when they're actually using it. So for example, biological safety cabinets such as a class 2B or greater, or even better a class 3, which is an isolator, and closed system drug transfer devices, CAD pumps, those are just some examples. So depending on the sophistication of the setup and activities, there might be more engineering controls to consider. So it's important that workers are educated on how to use these controls properly and maintain them so that they can function passively during the work activity. Administrative controls are controls where a worker must actively use to minimize exposure. So some examples are safe work procedures for splitting and crushing pills, dedicated areas for administration, preparation, or storage, communication devices such as like signs, lists, and policies, training, spill response procedures, cleaning practices. There's numerous numbers of administrative controls. So these typically go hand in hand with documentation, such as like spill procedures and communication methods and safe work procedures. And again, even more so with this control, worker education is important as they must know the appropriate procedures and recognize signs and symbols. Personal protective equipment, or PPE, is the last line of control. And these are pieces of equipment that workers wear to protect them from exposure. So this is an example of disposable personal protective equipment like fluid-resistant gowns, face and eye protection during spill response, and chemo-certified gloves. So just on a further note on gloves, the American Society for Testing and Materials International, or ASTM, has developed a protocol to test medical gloves and materials on the permeability of 9 cytotoxic drugs under continuous contact. And what they've done is they've mimicked worst-case scenario conditions and measured the breakthrough. For those of you that are interested, that's ASTM D6972-05. So what you want to do is look for this on the glove packaging or ask the manufacturer if they haven't done their own testing. Just out of personal experience, I know that Ample's done their own testing on their products, so you can always ask your Ample rep if there's any type of testing that's done on the particular glove that you are using. So again, I stress this again, worker education is important in knowing how to put on and take off the equipment so as to not expose themselves during the donning and doffing process or while using the personal protective equipment. So let's switch gears. We've talked a lot about controls and best practices on handling cytotoxics in the workplace. As mentioned at the beginning of the slides, not all best practices can be implemented. And from a real-world perspective, there are some challenges to implementing these practices that I've discovered from my experience. I've chosen 4 to talk about today. The first one is the differences in controls for hazardous drugs versus cytotoxic drugs. So from the risk assessment, you might find that hazardous drugs in your facility may not require the same control stringency as cytotoxic drugs. However, they are lumped into the same program. So it's important to differentiate between the two different categories and ensure that you have a site-specific program that is applicable to your work environment and conditions. The second is protective reassignment. So some organizations may choose to offer reassignment of duties for workers who are pregnant, breastfeeding, or attempting to conceive or father a child. And while this is a best practice, it might also be perceived that current controls in your work environment are not protective enough. It's important to communicate to workers that this is offered to those that may be more personally protective due to past experiences, and it's offered for comfort. There may also be challenges in coordinating the reassignment due to staffing and workload issues. The third is communication and education for workers. This is very key. However, there is a lack of occupational health and safety material that's easily accessible and directed at workers to learn about cytotoxic drugs. Often, maintaining a certification or license guides continuing education, and we found that there's an inconsistency in continuing education requirements for particular certifications that handle cytotoxic drugs. Also, there's a lack of prepackaged awareness material on cytotoxic drugs out there, so this adds more to the challenge. And finally, one last one is to mention the lack of universal cleaning protocol or agent when cleaning cytotoxics. There isn't one agent that can remove all cytotoxic contamination. It's important to note that there are different agents for different purposes. So deactivating agents such as hypochlorite breaks down the drug. Decontaminating agents such as detergents physically remove drugs. Disinfecting agents such as alcohol destroys bacteria. And cleaning agents such as chlorhexidine just removes the inorganic material or organic material. There are benefits and challenges to using each of these substances, but there is no universal cleaning agent. Again, these are just some challenges that I've found across the occupations. However, I recognize that there are more that are specific to certain groups and conditions. So this comes to the end of the presentation portion. There are some resources that are listed here. So 5 resources that we had talked about during our presentation. One from CAREX, one from WorkSafe. We've got 2 from Niosh, and then there's the compendium, the CPS for drug monographs. So now I'm going to hand it back to Allison.
Great, thank you, Percy. Now we're going to start the panel discussion and question and answer portion of our webinar. I'll introduce our panelists. So in addition to Amy and Percy, we have Cheryl Peters. Dr. Cheryl Peters is trained as an occupational hygienist. She has both her master's and PhD from UBC, and she directs the Occupational Exposures Program at CAREX Canada. We also have Chanya Pan. Chanya is an assistant professor with the School of Occupational and Public Health at Ryerson University in Toronto. He's been researching occupational exposure to antineoplastic drugs for more than a decade. Here at WorkSafe, we have Kelsey Van Pelt. Kelsey is a research and evaluation analyst at WorkSafeBC and was the content lead for the publication that Percy mentioned, Best Practices for the Safe Handling of Hazardous Drugs. So we'll start with a few that I believe are directed at Amy, but I'll encourage our other panelists to speak up if they have anything to add. So the first question is, can you expand on risk of cancer as related to chronic low-dose exposures to workers?
Yeah, there have actually not been as many studies done on this issue as I would have thought. Basically, there have been some links found between, and I'm not sure if the question is about specific cancers, but there has been increased risk of breast cancer noted in some long-term studies of, I believe it was nurses, rectal cancer, increased risk, as well as, but the research base is not highly developed. The evidence base is not, it's not huge, but there have been a few studies that have found those types of long-term exposures at low levels, presumably.
Okay, then I'll move on to the next question. Was there any opportunity to look at subcategories of nurses? For example, nurses on dedicated oncology units. Again, this is a question for Amy.
Yeah, there was, and that's not something that's obvious from the diagrams that we presented, but we did actually base our level of exposure estimates, the categorizations, on where a nurse worked. So those working in oncology areas, I think, ended up in they were categorized differently, so they were identified as having high frequency of exposure. So in terms of detail across types of nurses, that will also be available. We have a publication being peer reviewed right now with a lot of detail on how we came up with these estimates, and I'm not sure if that level of detail will ever be on the website, maybe not, but it will be published, so there will be access to that kind of information for all of the occupations in terms of the specific ways that we broke down the exposures.
Okay, great. Thanks, Amy.
But I have to say, I will follow that up with nurses are probably the nurses and pharmacists have the most information on them in terms of general exposure scenarios, so that level of information will be available for every occupation.
A follow-up question to the first one actually related to breast cancer. So the increased risk of breast cancer in nurses, is that linked specifically to antineoplastics?
As much as it could be. So it was looking at nurses working in oncology areas and assessing their exposures associated with risk. Yeah.
Okay, thanks. The next question is for Percy. Are there situations in which WorkSafeBC would recommend biological monitoring?
Are there situations where biological monitoring? No. There aren't really any specific biological monitoring markers or tests out there. So if there were biological monitoring, it would have to test for specific metabolites within urine or blood. I believe there's some research that's being done out there, and Chun Yapon would be able to comment on that.
There's still a lot of controversy regarding a specific biological marker. So the short answer is there isn't really anything specific for exposure to hazardous drugs or antineoplastic drugs at this time.
Okay, thanks, Ken. We're going to move on to a question. The question is there any study or any data on pharmaceutical manufacturing workers exposed to antineoplastic active pharmaceutical ingredients?
In terms of exposures in those workers in manufacturing? Yeah, that's it's Amy again. That is one of the reasons, actually, that we did not include these workers in our estimates, is that we weren't able to locate any information. It was really hard to even determine where these drugs were being manufactured. As far as we can tell, it's based on what we got, we're not certain that they are being manufactured in Canada, but yeah, it's been quite a challenge to get information on exposure within these types of work environments. So if anybody has any feedback on that.
Yeah, it's Chun here. I just want to add to that. I was just doing a quick search on my university's library. There was a paper done in 1988 by Sorsa et al., which looked at cyclophosphamide, which is one of the common antineoplastic drug markers for these type of studies in industry. However, it is quite dated, so it's really hard to say whether or not it has any relevance to current practices because of the age of the paper, but certainly I can provide the citation over to Allison, who can then share to the rest of the individuals who are participating.
That's great. Thanks, Chen. Okay, so move on to our next question. There was a discussion here about the ASTM standard number for cytotoxic gloves. Percy, can you speak to that?
Sure. So just to repeat, it's ASTM D as in Delta 6972-05. And that's the, lots of numbers, standard practice for assessment of resistance of medical gloves to permeation by chemotherapy drugs. So that's very specific to chemo. There is another ASTM standard out there, which is F739-99A, which is non-specific. Yeah, ASTM just can't make them single numbers. But there's also another recognized permeation standard out there, which is a European standard, which is also non-specific. And for those of you who are interested, it's EN 379-3.
That's great. Thanks, Percy. There's a question here, is there a plan for CAREX to work with other provincial WorkSafe teams? And the answer is absolutely. So I would maybe put that in the category of requiring a follow-up conversation. So please do get in touch and we can start that conversation. That's a great question. So the next one is for drugs not yet listed on the Niosh or BC Cancer Agency listing due to newness, what tools can be used to determine if the drug is hazardous or cytotoxic?
I guess I can answer that. It's Percy here. So going back to the slide about just how to identify, so the identification process, definitely looking at asking the manufacturer for the material safety data sheet or SDS, and definitely talking to the supplier about the hazards that are associated with the drug as well. They can provide some more information. Definitely you want to look at, definitely going through again, looking at the factors again, determining how workers are being exposed, what kind of potential health effects that you might get from exposure. Is it a mild one versus a more serious one? But then also looking at you can also look into scientific literature, so looking into some of the Medline research, PubMed, seeing what kind of exposures are reported out there in animal studies or epidemiological studies. So some ways of actually finding out a little more about the drug itself.
Great. Thanks, Percy. So we'll carry on here. There's a lot more questions flowing in. Is there evidence to support protective reassignment for pharmacy staff who are working in a clean room with engineering and administrative controls?
Sorry, this is Percy here again. I can only speak on behalf of the BC Occupational Health and Safety Regulations, which states that protective reassignment must be considered if a worker is handling reproductive toxins. And so it must be considered. However, what I said in the presentation was that it could be a challenge because some individuals might perceive it as thinking that the controls aren't really working within the work environment. So protective reassignment is pretty much used just for comfort of the worker, just so that they're more comfortable with working with their work duties and working with the substance units. So that's provided that the engineering controls, administrative controls, and personal protective equipment are all functioning and working properly. I did mention white sampling, and I know Chen has done some research on white sampling, and perhaps maybe Chen can comment on contamination.
Right. So basically, in my work, which was mainly focused in acute care centers in British Columbia, we looked at contamination of surfaces throughout the hospital. The summary of that is that we did find contamination in multiple departments within a facility, but I think what's more of a damning statement about this whole contamination issue is from Dr. Tom Connor with Niosh in the States, where he stated that every paper which has examined environmental contamination has found at least one sample with detectable levels of residual drug on the surfaces. So needless to say, I think contamination is a problem in acute care facilities anyway.
I mean, I can elaborate on that a little bit. It's certainly contamination of surfaces has been also noted in veterinary settings pretty extensively. So we know that it is happening, and in community pharmacies as well. And I believe there's 1 or 2 papers that have looked at home care, but it's a pretty low data kind of area at this point. But it's certainly happening where they're used.
Okay, and if you'd like some references to be sent to you on these specific questions as follow-up, we're happy to do that, so please do get in touch with us, the info@CAREX account. So carrying on with the questions here we have in the chat box, this is another one for Percy. Can you confirm if health monitoring is required for those workers preparing or handling cytotoxic drugs? At one time, we would offer serology testing, for example, CBC, liver function, etc.
Yeah, so we had commented about this earlier in the question period. It's, as Chum said, it's very controversial, and really there isn't any specific types of handling or specific types of tests. As you had mentioned, that you do actually just monitor for CBC, white cells, platelets, liver function. Nothing really specific that would indicate exposure to cytotoxics. So there isn't a real good evidence and scientific basis behind health monitoring for workers that might be preparing or handling cytotoxics as an indication of exposure.
Great. Next question is there some place to get information on the appropriate cleaning agents for specific drugs? Another Percy question. Or perhaps a Kelsey question.
Hi, this is Kelsey from WorkSafeBC. So there is a little bit of information on that in the WorkSafeBC publication, Best Practices for the Safe Handling of Hazardous Drugs. And if you go to that publication, there is a section on cleaning. So you can take a look at that. And then there's also some information on where that information came from in the appendices. You can take a look at the references in there. But definitely start at the Best Practices publication first and take a look at that.
Okay, thanks, Kelsey. Next question is about residential care. In residential care, should each resident that is on oral neoplastic meds have chemotherapy spill cleanup kits in the resident's room for any bodily fluid exposure risk that could occur?
So it's Percy again. I realize that residential care, the residents' rooms can be quite cramped. And it's not necessary to have a spill cleanup kit right immediately in the room, but it needs to be available. So perhaps at centralized nursing stations or somewhere that you could quickly run and get the spill cleanup kit. It shouldn't be more than maybe a dozen steps away from the entrance of the residents' rooms. But yeah, if I realize in terms of space constraints in residential care, so it's not necessary. Great idea to have one, but it's not necessary.
We've got another question. Is there anything available in the literature that indicates impact of different controls or interventions on exposure? For example, single glove versus double glove, chemo-rated gown versus fluid-resistant gown.
There is a lot out there. There definitely is a lot of literature out there, scientific studies, and I'm sure we could probably spend all day talking about this. And it looks like you're concentrating on mainly personal protective equipment. So if it's mainly PPE, such as gloves or gowns or shields or masks that you're interested in, I would definitely contact the manufacturer of the PPE. So I come back to Ansel. Ansel has done a great job in terms of doing some scientific research and doing permeability studies on some of their equipment. So they could provide you some information that's not available within the scientific literature, but they could provide you some good scientific studies on permeability of their PPE. And I swear I'm not an apple rep or anything like that. So.
All right. So it looks like one last question we have here. I'm not sure that it's a question or more of a comment. For new cancer drug class of monoclonal antibodies.
So monoclonal antibodies right now are classed within hazardous drugs, but I'm not quite sure if they've actually made it to the cytotoxic drug category. So if you look within the Niosh listing, the 2016 listing, which has the list of hazardous drugs and antineoplastic drugs, monoclonal antibodies are in there, but they are not classified under group 1, which are the antineoplastics or cytotoxics.
Great. Next question. Any idea on how we should deal with hazardous drugs that are not cytotoxic? For example, class 2 or 3 of Niosh's 2016 list.
So again, going through that risk assessment process and looking at looking at the different factors of risk that are associated with risk assessment. So looking at how they're being exposed. Probably the most difference is the potential effects from exposure. It'll probably be on the more acute side of things and more on and less severe health effects from such as cancers or anything that comes from that. So looking at that and then matching the controls to determining. Let me go back. So you've looked at your assessment and then you've determined the extent of exposure to be either low, moderate, or high. So typically with the class 2s or 3s in the Niosh list, they're more on the low or moderate extent of exposures. And then matching those up to the controls that are available and applying those there.
The next question is there any information on the exposure risk for medical laboratory technologists who collect and test blood and urine specimens from patients who are receiving antineoplastic drugs?
It's Amy here. I'm not aware of any. No, I don't know if Chun has ever encountered.
Not for that particular job cohort, no.
So maybe we'll wrap it up here and encourage those of you who have any further questions to please get in touch with us. And we'll thank you all for your participation and for your questions. We've heard some really great questions today, and we have taken notes on those. So if you would like to see a copy of those, we'd be happy to share them with you. So please do let us know and get in touch with us with any further questions. Thanks so much.